This film is aimed to disclose our recent efforts to develop alternative techniques to improve anterior chamber stability during micro-incision cataract surgery, and also to improve the capsule safety factor of ultrasonic lens removal. Phacoemulsification has been perfected into the safe, fast, and predictable technique we know today. Further reduction of incision size had been limited by the coaxial modality of irrigation aspiration, necessary to provide adequate inflow and proper ultrasonic tip cooling. Recent improvements in ultrasound power modulation allow the insertion of a bare phaco tip through a watertight incision without the threat of a corneal burn. This cold phaco concept has produced an increasing interest in micro-incision cataract surgery, where irrigation and aspiration take place through separate, very small incisions. Reduction of irrigation port dimensions limits inflow capacity and produces anterior chamber instability. Low settings for aspiration rate and vacuum must be used to avoid complications. The typical gravity-fed infusion system used for classic phacoemulsification has proved insufficient to provide adequate inflow to the irrigating instruments used for mix. One solution has been to pressurize the irrigation line fluid using compressed air applied internally or externally. Although this solution may improve inflow and protect from chamber collapse, big IOP fluctuations are observed related to the amount of fluid exiting the eye during the operation. Pupil contraction, sonular problems, and optic nerve damage are some of the potential risks of these extreme IOP fluctuations. For these reasons, dynamic inflow control systems are under development to detect the real outflow and generate an equal inflow. These solutions are complex, expensive, and still unreliable. We propose a simple concept that can help us to approach the fluidic imbalance challenge of mix. The output volume of the aspiration pump of a phaco console is equivalent to the pump input volume being aspirated from the eye. Fluid exiting through the output port of the aspiration pump can develop high positive pressure. Based on these two concepts, a fluidics cartridge was modified to redirect the waste fluid towards the infusion line. An isovolumetric exchange bottle was used to convert the waste fluid volume into clean BSS. We used an artificial eye chamber and animal eyes to determine surge, IOP, irrigation, and aspiration line pressures using mixed instrumentation. This modality of operation was named closed-loop IA, in opposition to the typical open-loop configuration. We could determine that the closed-loop system was able to maintain a stable anterior chamber using aspiration parameters that produced big fluctuations and even permanent negative balance in the standard open-loop modality. Considering that no surgery can be made absolutely leak-proof, a compensating mechanism was introduced by using a console-controlled valve to refill the lost volume while in foot pedal position 1, and also periodically during extended operation in positions 2 and 3. Surprisingly, intraocular pressure showed an increase proportional to the vacuum levels in the aspiration line during occlusion. The introduction of a venting pinch valve in the irrigation line allowed to cancel this undesirable behavior. A special hydrophobic air extracting filter was included to remove all unwanted bubbles in the fluidics system to help maintain a predictable performance during operation. A complementary approach to solve the problem of IOP rise on occlusion was the incorporation of an active volume compensator in the positive pressure side of the fluidic loop. A formula determining the excess volume responsible for IOP rise as a function of vacuum was developed. A linear actuator was used to drive a plunger reacting to vacuum readings to compensate the volume shifts that produced the IOP rise. Reducing the response time of our dynamic compensation system will also allow to cancel the pump roller spikes observed in the irrigation line. We have accomplished to actively balance the inflow and the outflow of a lens removal system using a relatively simple and inexpensive closed-loop solution. Implementation of this system may allow further reductions in the incision size required for the irrigation instruments. On another aspect, the current interest in refractive lens exchange and the new developments in IOL technology have stressed the issue of capsule integrity. A ruptured capsule increases complications and may totally prevent the use of the intended IOL, frustrating the patient and the surgeon. Laser photolysis and more recently, waterjet-based lens-removing technologies have been introduced and claim to be capsule-friendly due to the blunt nature of the probe tip. Unfortunately, all these systems are less efficient than ultrasonic-based systems, being unable to adequately handle hard cataracts. In fact, most of their lens-removing capabilities may derive from the greatly enhanced fluidics of the modern consoles. In the meanwhile, ultrasound has proved safe for the endothelium and less prone to produce thermal injuries, covering the full spectrum of cataract densities. Close contact of the lens capsule with any metallic instrument, even blunt, may promote rupture mainly by the presence of tiny burrs and spurs. It has been demonstrated that the posterior capsule will withstand maximum vacuum without rupture when aspirated with an elastomer-covered IA instrument. Supposedly, ultrasound would not traverse such elastomer layer in an efficient or harmless way. Using a special slow-motion recording technique, we were able to determine that an elastomer-capped, blunt phaco tip was able to adequately emulsify relatively dense cataract material using low US power. We also demonstrated in the animal eye that this elastomer-capped phaco probe was friendly to the capsule in the same way silicone-covered IA handpieces are, even when ultrasound power was applied. We constructed a surgical-grade soft-tipped phaco probe prototype and performed real surgery in a few human subjects. The typical surgical steps of sculpting the nucleus and performing phaco chop were completed adequately even in relatively dense cataracts. Furthermore, the soft phaco tip was efficient to remove the epinucleus and the residual cortex safely without the fear of a capsule rupture. With the background data on capsule safety of elastomer-covered IA handpieces, we were confident to aspirate residual fibers from the posterior capsule without any problem. We strongly believe that an elastomer-capped, blunt phaco tip provides maximum capsule protection, while being at least as effective as any of the currently promoted non-ultrasound-based lens-removing methodologies. Also to consider, this soft-tip phaco probe concept uses the installed base of ultrasonic phaco consoles without any modifications. An active fluidic balance concept for mix based on positive pressure generated by the aspiration pump is presented. A phaco probe concept having a blunt tip covered by an elastomer membrane is shown effective to remove even hard cataracts. At the same time, this probe is capsule-friendly, being ideal for phaco-refractive procedures using standard ultrasonic equipment. Ultrasonic phacoemulsification seems to be evolving ahead of other methodologies. This film is dedicated to the memory of the visionary man who introduced this technique, Dr. Charles Kelman.
One day I'll fly away, leave all this to yesterday. What more could your